Abby and a very special guest. And before starting, I would like to tell you about a survey that we're launching to better understand your availabilities and how to make VMR more accessible to you and make VMR better. It's a very, very short questionnaire. You can fill it in under 1 minute. Yeah, I'll be sending it in the chat every 10 to 15 minutes. And yeah, with that, let's get started. I'll pass the mic to you, Ravi.
Hello, everybody. Can you hear us? Yep. Okay, I guess Reza will be joining soon, but I have this case that my intern today, Ariane Thomas, is kind of going to present, kind of have the same people present usually. But it'd be great to actually have Ariane present this case that we actually had about 2 weeks ago, and we'll see if the audience can go through the case and decipher some of the data to see what the diagnosis is. So it is a little unusual presentation, which I'm sort of dwelling on and learning from. So I think it would be high yield for the audience here. So I'm going to ask Ariane to introduce herself and tell us a bit about herself, where you're from and what are you doing currently.
Okay, hello, my name is Ariane or Ari. I'm a PGY1 prelim here at Sinai. I'm going into PM&R next year, or later this year in July, here at Sinai too. I'm originally from Inglewood, California, so the LA area on the West Coast. And I went to med school at Howard University in Washington, DC. So this is my first year here at Sinai, and it's been great so far.
Awesome. And Ariane, what do you like to do in your spare time?
I like to do photography. I haven't been able to do it as much now, but last year when I was at M4, I did a lot of grad pics for my friends, and then I used to do sports photography too. So I wish I can do more now, but in the future, for sure.
Awesome. And I think you have an interest in sports too, right? So
yeah, I would like to do sports medicine through PM&R. So that's my goal as of right now. So
exciting. And you also told me you did some, you spent some time volunteering with the LA Sparks,
yes,
the women's basketball team.
Yep. So back when I was in med school and the summer before, I did an internship with a sports trainer. That's the sports trainer for the LA Sparks, the women's basketball team. So that was fun, and just different basketball leagues in LA as well. I was helping out with that. So sports medicine is kind of my thing right now.
Yeah, that's when I met Ariane for the first time, that was something we connected on. So a deep-seated interest in sports and basketball and so on. So I'm waiting to see if Reza is on yet.
Hey.
Oh, hey, Reza, how are you?
I am well. How are you?
Great. So I have a case today, which Ariane, I don't know if you listened in. Ariane is going to present the case.
Hi,
and,
Ariane.
Hello.
And she actually is from LA as well. So
why did you move to the wrong coast?
I know, it was for med school, and then now I'm still here for residency.
Well, we got to get you back.
I know.
So yeah, he was in Baltimore at Hopkins and visited us here twice.
Oh wow!
And then went to the West Coast. So he's the VA. You know, when you go from the airport on, is it 495?
I know exactly.
You see, yeah. So whenever I go back to LA, my wife's from there. I pass by, I kind of wave like.
Right, wave at the VA. That's so cool.
So Ravi, what do we have in store? You said you guys have a case.
Yeah.
Yes, we do.
Yeah. Okay, so we'll start with the chief complaint, and you tell us if you want more information or not, then we'll continue on with the other quotes.
Wonderful.
All right. So for the chief complaint, it's a 53-year-old male with weakness, fatigue, intermittent low blood pressure with dizziness and mid-abdominal pain that radiates to the right flank.
Do you want the HPI? Should we?
No, honestly, maybe I'll just make a quick comment here. And by the way, I know Robbie may or may not join, but hopefully the chat will be busting with ideas as we solve this case. I think one of the most important steps in clinical reasoning is identifying your anchor point in problem solving. Meaning here we have multiple concerns, but which one should you really invest your cognitive energy in? For example, fatigue, very non-specific. I slept a couple hours last night. I am extremely fatigued, but it's because I just didn't sleep. Weakness is usually non-specific too, unless you can prove objective weakness. For example, the patient is unable to get up without using their arms. Then all of a sudden you would activate this script for where is the focal neurologic abnormality. So I'm putting fatigue and weakness to the side. Dizziness, that too can be a tough concern to approach unless it's the main concern of the patient, meaning that that's their only concern. It's so severe, then you have to activate your schema for dizziness, primarily ruling out strokes as the acute emergency causes of dizziness. Of all of these findings, there's two that are most compelling. One, which has to do with the emergency of management, and that is the low blood pressure, because low blood pressure will make anyone feel weak, dizzy, fatigued. So that you have to put your full attention and focus to, but then you can use the abdominal pain that's radiating to the flank as supporting data to make progress in your schema for hypotension. Before I share a schema for hypotension, it's going to be important for us to know what were the blood pressures of the patient. Maybe this is someone who went to a primary care clinic where they checked the pressure, or a cardiology clinic, and they're like, you have to go to the emergency department because your blood pressure is low. So I'm not going to share an approach. I'm just going to comment on one thing really quickly with the blood pressure. If you say someone is hypotensive and you think about those 4 buckets really quickly: hypovolemic, obstructive, distributed causes of shock, and cardiogenic, if you put in mid-abdominal pain and flank pain, the one diagnosis that you can't miss is something like an aortic dissection or a AAA rupture. Those are emergent causes. So with that being said, Robbie and Ariel, I would love to hear more from you.
Absolutely. So a little bit more about the patient. He's a 53-year-old male with a past medical history of hypertension and hyperlipidemia. And he presented, as we mentioned before, with abdominal pain and lightheadedness. He said that his abdominal pain has been happening for the past 3 months. And he says that it's located in the epigastrium and in the right upper quadrant, and it radiates to his lower abdomen. And he says that his pain was rated a 6 out of 10 when he first came in. And after receiving morphine, it was a 1 to 2 out of 10. So the morphine helped relieve the pain. And then in regards to him describing more of the pain, he said it was burning in quality, and it was aggravated by sitting or standing. And as we mentioned, it was relieved by analgesia with no associated nausea, no vomiting, no diarrhea, and no constipation. Also, he complained of some lightheadedness at the time of presentation, but then it resolved throughout his stay in the ED. He also said that he had some weight loss of about 30 pounds over the past 3 months due to a very poor appetite, but he felt very thirsty and said that he had been drinking a lot of water. He also had been taking NSAIDs for the last 6 to 8 weeks for the pain that he was having in his abdomen. For a quick review systems, he denied any fevers, no chills or shakes, no chest pain, and no dyspnea.
Ariel, I have to say, you're a master presenter. What a story you're painting for all of us. Very interesting case. And one thing I neglected to comment on in the first aliquot is the intermittent nature of that hypotension. That may be relevant as this case unfolds. But let's comment on the second aliquot where we got a lot more information. So it seems that the chief concern to the patient is abdominal pain. And this isn't acute onset abdominal pain, but rather you would frame it as subacute based on the duration. And it starts in the epigastrum. The thing with abdominal pain is you often want to use the anatomical site of the abdominal pain to make progress on the DDX. But the issue with that is that these organs are so packed within the viscera that something happening in the right upper, like the liver, can cause pain in the left upper quadrant. Something happening in the spleen can manifest as epigastric pain. But let's say you were definitely dealing with epigastric pain. That's when you have to think about the Gs. And the Gs include gastritis, gastroparesis, GERD, gastric ulcer disease, and peptic ulcer disease. And there's a few complaints like constipation, colitis, and abdominal aortic aneurysm that can also manifest as epigastric pain. But here we're not just dealing with epigastric pain, we're dealing with epigastric pain that's radiating more towards the right side. So that could mean that whatever pathology started within the epigastric region is now leaving a footprint on the right quadrant of the abdomen. It's going to be very hard to make more progress from an anatomical perspective, meaning at the end of the day, it's almost like you need some form of imaging to try to identify a site of pathology. But here we have other data to help narrow our differential diagnosis or potentially broaden. And one of those pieces of data is the weight loss. 30 pounds of weight loss. Think about that. I'll share a quick story. During the holidays, I was eating very unhealthy, like many of you, so don't judge me. And I had gained, I think, 5 or 6 pounds over the span of a week or two. So I was like probably 3,000 calories positive a day. Then I got a GI virus or a foodborne illness, and I couldn't eat for a couple of days, and then I shed off the weight because I had lost it rapidly. So in part, I was grateful for that gastrointestinal illness. But the point I'm trying to make here is that it's very hard to lose 30 pounds. When you see someone with 30-pound weight loss, your first branch point is there some form of inflammatory process, whether it's infection, malignancy, or autoimmune? Or is there an issue with acquisition of food, chewing of food, swallowing, or absorption of food? It's very conceivable that someone can have epigastric pain from celiac disease and then have malabsorption, or have epigastric pain from pancreatitis and then have malabsorption. So you can't really say that this is inflammatory for sure. This can still be non-inflammatory, but that's sort of the way I'm thinking about the weight loss and the abdominal pain. The improvement with morphine doesn't do anything for me. Like, morphine should make anyone feel better, whether they have pain or they don't have pain. So that qualifying information isn't too helpful. The standing up, I note that that's just very peculiar, like an abdominal cause of pain that gets better with standing up. Usually when we think of posture, we think of it influencing blood pressure and lightheadedness. All the NSAID does for me is to say, could this patient have an additional cause of abdominal pain, like a peptic ulcer disease from taking so much NSAIDs? But it wouldn't explain what caused the first cause of abdominal pain. Then we have something pretty unique here, Ariel, and this is the drinking a lot of water. Why is this patient drinking a lot of water? And I assume, and I think this will be the case, that they're drinking water for a good reason, as opposed to acute water intoxication that may occur in patients with psychiatric disorders, where you'll see that they're hyponatremic. I think with the intermittent hypotension, the lightheadedness, I have every reason to believe that this patient is hypovolemic and that they're drinking water to compensate for their volume deficit. So either they're polydipsic, because I think they're losing volume from somewhere. We haven't been told that the patient has polyuria, but that's something I would explore with them. Have they been urinating a lot? Because then we can talk about polyuria, but I'm not yet ready to make that leap. And the final thing I'll say here, if you say epigastric pain, some nausea, some weight loss, you have to think about adrenal insufficiency. Like that has to cross your mind in such a patient. So where would I go from here? Of course, we'll round out the medications, the health-related behaviors, the physical exam, but I'm really curious to see what the laboratory data show and what the imaging shows for this patient.
Okay. All right, so in regards to his medication, he was taking Prilosec, 20 milligrams PO daily. He was taking rosuvastatin, 20 daily as well. And then tamsulosin, 0.4 daily. He was previously on HCTZ, lisinopril combination 20 and 12.5, but he hasn't been taking it recently since his abdominal pain started. And in terms of his vitals, his temperature was 36.6 Celsius. His heart rate was 86. And his respiratory rate was 13. His BP supine was 100/68. Sitting was 101/70. And standing was 64/45. And then for his physical exam, for the general aspect, he was awake, alert, no obvious distress, but he had generalized weakness. In terms of his head and neck exam, his flare was anicteric. He had pink conjunctiva and his mucous membranes were moist. For cardiovascular exam, he had regular rate and rhythm, no obvious murmurs. For his lung exam, his lungs were clear to auscultation bilaterally. For his abdomen was soft, non-tender, non-distended, and he had normal bowel sounds. For his extremities, no edema, normal range of motion. And just to mention, going back to the abdominal exam, he didn't have any pain on superficial or deep palpitation.
Wow, wow, wow. Is that the end of the exam, Ariel? Or
Yeah.
okay. The reason I say wow is because suddenly we have, I'm not ready to say yet our pivot point, but we definitely have an updated frame on our problem representation. And we have a 53-year-old, I believe, man, is it a man, Ariel? I don't want to mess up the gender of the problem representation. So we have a 53-year-old man who's presenting with 3 months of epigastric pain, comma, significant weight loss, comma, and striking orthostatic hypotension. That's the frame. And I think we already talked a lot about the abdominal pain, and we'll try to link it with the orthostatic hypotension. But right now, all of you should be investing your cognitive energy on what causes orthostatic hypotension. So you see, when we started this whole clinical problem-solving exercises, we had 4 buckets for hypotension, but now we have a qualifier being orthostatic hypotension. So we can make more progress on that initial chief concern. And when you're dealing with orthostatic hypotension, I'm going to first teach you an easy way to think about the main buckets of orthostatic hypotension, but then we can get much more granular if needed. The main approach is, one, look at the medications. Quickly look at the medications, because ultimately, let's talk a little bit about the pathophysiology. What is blood pressure? Blood pressure is cardiac output times the systemic vascular resistance. Cardiac output is heart rate times stroke volume. So anything that interrupts that formula can lead to orthostatic hypotension. Because when I go from a supine position, so you lay the patient down for a minute or two, and then when you tell them to stand, what happens? Blood pools into the lower extremities. So to keep you from dropping your blood pressure, you need to activate the sympathetic nervous system. You need to cause vasoconstriction. You need to increase the heart rate, the contractility, to prevent a drop in blood pressure. So we know that there's a lesion somewhere in that formula that's causing such severe orthostatic hypotension. So look at the meds. Is there anything like a beta blocker that might be preventing the sympathetic nervous system from causing vasoconstriction? So I'm looking at his med list. He's on tamsulosin, and tamsulosin can certainly cause orthostatic hypotension, but this is when you have to apply the law of proportionality. I've never seen 0.4 milligrams of tamsulosin cause such debilitating orthostatic. It would be very, very odd. Tamsulosin usually leads to lightheadedness, but not such striking changes in blood pressure. And then we see that the patient was previously on hydrochlorothiazide and lisinopril. Hydrochlorothiazide is a diuretic, and if you're hypovolemic, that can cause orthostatic hypotension. That's the second most common cause, hypovolemia to some reason, some cause, some etiology. The lisinopril, being an ACE inhibitor, is going to also cause a drop in blood pressure, but the patient hasn't been on these medications, it seems, for some time. So the natural approach to orthostatic hypotension is review the meds. Are they on any diuretic, any beta blocker, any antihypertensive, any agent like tamsulosin? Look at their volume. Is there any reason for them to be hypovolemic? And this is when you might actually ask hypothesis-driven HPI questions, meaning your exam gets you back to the HPI. Like, sir, have you been vomiting? Have you been having diarrhea? Have you been peeing a lot? Remember, he's been drinking a lot. So I really think that there is going to be a component of hypovolemia here. But we'll wait and see. And then the third category, so we said meds, volume, and the third category, this is usually something wrong with the autonomic nervous system. It goes back to our formula, SVR, heart rate, stroke volume. The most common problem here would be diabetes, but other stuff like Parkinson's can do that. And even less common etiologies like amyloidosis, AL amyloid. I remember we had a patient at Hopkins. The only chief concern was orthostatic hypotension, and we only diagnosed it based on serum-free light chains. There was no other evidence of AL amyloid in that patient. So what would I do for this patient, honestly? One, you got to make sure that this patient doesn't fall, because if they're getting up and they're lightheaded, they might fall and have a complication of that. So you got to put on fall precautions. And two, I would get the CBC, the liver chemistry test, the renal panel, proBNP. I'd be curious to the heart function. And then after doing all of that, I would have Ariel present some more data, and then I'd pass the mic to Robbie to swoop in.
Yo, isn't he amazing? Prof. Rez, I haven't heard you solo discuss in a crowd for a long, long time. I was in and out, but I caught most of it. And the pathophysiological breakdown is epic. I will bask in your glory, my friend.
Well, you're up next, so don't pass too long. And you can see we have a problem representation right there, Robbie. And Ariel, out of Sinai Hospital, is presenting with our dear friend Robbie.
Beautiful.
All right, so next I'll give the labs. So for the white blood cell count, it was 9.47, so it's normal. Hemoglobin was 19.3. Hematocrit was 15.2. And the platelets were 355,000. For the CMP, sodium was low at 129. Potassium as well at 3.2. Chloride was 91. The bicarb at 29.2. BUN was 18. Creatinine 1.01. Glucose 120. For the calcium was 7.8. The phosphorus was normal. The phosphorus was normal. In terms of the albumin, it was 2.2. And previously, 3 months ago, his albumin was normal at 4.5. For the outphos, it was 160. The liver enzymes, AST was 77. ALT was 33. And total bili was 1. And then the total protein was 4.7. Yep, and then the calcium, I think, oh yeah, the calcium 7.8. Oh, no. Okay, and for more labs, so the coagulation profile was normal. The thyroid panel, his TSH was 11.4. His free T4 was 0.66. And free T3 was 1.5. And then his urine analysis showed the specific gravity was greater than 1.06. He had 2+ heme, 3+ protein, positive for hyaline cas, and then 16 red blood cells and 21 white blood cells. And then for his serum osmolality, it was 289. The urine sodium was 50. The urine osmolality was 530. And then the serum uric acid levels was 5.5, which was normal. And that's all for all the labs.
Wow, I feel like I was sitting in a limousine, like relaxing, and somebody was just like eloquently and effortlessly presenting the labs. Unbelievable. There's a lot to work with here. And Prof. Rez, I'll just try to summarize the labs and maybe you can synthesize them in the context of what you've been thinking about. And I think the first thing is the striking disconnect between what you might expect the hemoglobin to be and what it is. And somebody who you're worried might be hypovolemic, for example, with those orthostasis, you see a high hemoglobin, like, weird. I think the first pass reflection is to worry that the patient has some sort of vascular leak process, meaning that that plasma is leaking out of their vessels, concentrating their hemoglobin, contributing to hypovolemia because the plasma is lost into the tissues. And that concern is corroborated by the constellation of hypoalbuminemia and proteinuria, because that combination evokes not quite nephrotic syndrome because there's no edema, but rather the possibility of nephrotic range proteinuria, which is on a spectrum with nephrotic syndrome. And that, of course, is a rapid analysis and marrying two findings, each of which have a very different differential diagnosis with maybe no definitive overlap. So that's how I would try to simplify it. I'd say like, hey, no, I'm not quite getting nephrotic syndrome, but I can easily connect the hypoalbuminemia and the protein loss, and then say maybe there's vascular leak and that's causing the hemoconcentration. Of course, you want to stop for a second and make sure you're not missing life-threatening causes of an erythrocytosis, which would include a renal cell carcinoma and EPO, which would include the myeloproliferative neoplasms like P. vera. And the life-threatening dimension of them may be that they are causing a vascular catastrophe in the belly, which I know Reza already mentioned. So I think the shortcut exercise that I'm trying to do in terms of rapid thinking, which is not capturing the base rate, is to say what kind of nephrotic diseases cause an orthostasis syndrome beyond just the volume. And that's where diabetic autonomic insufficiency and diabetic nephropathy come into play. But the patient's glucose is normal, which is not a great test, but as a decent enough test. And then the most esoteric connection would be to worry and wonder about amyloidosis, which definitely infiltrates the peripheral nerves and also infiltrates the kidney. That's the sort of rapid thinking of how this might all come together. But I think you have to think about the polycythemia, the proteinuria, and reflect on the hyponatremia separately. And I'll just say that the quick thing about the hyponatremia before I pass the mic to Prof. Rez is on the surface, it looks like you're dealing with a ADH appropriate hyponatremia when the urine osms are higher than the serum osms. And the caution you may say is, wait, hold on, the urine sodium is high. Isn't that SIADH? Unfortunately, if you're invoking some sort of glomerular or tubular issue by virtue of the proteinuria, the urine sodium becomes less reliable. And so it could be compatible with SIADH, but it could be compatible with appropriate ADH plus intrinsic renal disease. And yeah, those are my reflex thoughts on the labs. What do you think, Prof. Rez?
I think that's terrific. I really don't have too much to add. If I had to layer this on the discussion that I was having with the group, is that I think there is strong evidence for hypovolemia of some nature, just given that the patient is drinking a lot of fluid, the patient is orthostatic, and I personally think the labs reflect hemoconcentration, just based in the context of this case. And I will say, when I saw that sodium, my initial thought was, could this be adrenal insufficiency? But then that was a bit calmed down by looking at the level of the bicarb being high and also looking at the potassium being low. So not to say that it would completely rule out, but it makes it less likely. I would still send a AM cortisol in this patient. Why? Because adrenal insufficiency can lead to hypovolemia. It can cause or mimic an SIADH picture and give these urine studies. But at this point, since I'm not sure, and I think there's one main concern, and that's like, what is happening at the level of the glomerulus? So it's going to be really important to spin that urine. Can we be dealing with a glomerulonephritis? Is it possible? Oftentimes when you're dealing with GNs, especially if they're rapidly progressive, you will have some form of AKI, you will have some form of hypertension, and there will be edema or something. There's more than just this. That being said, it's almost like a troponin elevation. You still got to respect it and say, are you dealing with the GN? So this is a patient where I would repeat the UA, I would spin the urine, because if we're dealing with the GN, that's a totally different, schema that we activate. So what am I doing now? I'm getting a CT scan of the abdomen and pelvis with contrast. I am spinning the urine and hoping that CT gives us some form of answer. But I think Robbie's point about the urine having all these cells in it really takes away our ability to put too much strength on the urine sodium and say, hey, this has to be adrenal insufficiency or this has to be SIADH. Back to you, my friend, Ariel.
Okay, so for imaging, for the ultrasound of the abdomen, it showed hepatic cysts, small ascites, and cholelithiasis, and non-specific gallbladder wall thickening. with a negative sonographic Murphy sign. Then the next imaging would be the CT abdomen and pelvis with contrast. And that one included no pulmonary emboli, small pleural effusions and ascites, as well as multiple small gallstones. And they noted no acute inflammatory changes in the abdomen and pelvis. The next one would be the CT angio. That one was concerning for pancolitis, likely infectious more than inflammatory or ischemic. It showed pericholecystic fluid with wall thickening, concerning for cholecystitis, benign liver cyst, and a left renal cyst. It also showed thickening of the gallbladder wall with enlarged prostate, concerns for obstruction, infection, or cystitis. The upper endoscopy and colonoscopy to further look into the patient's nausea and abdominal pain and weight loss was done. And he also started to have maroon colored stool. So the findings for the upper GI endoscopy showed a mass in the pylorus, which was bleeding, and it extended to the up to the first portion of the duodenum, which was also biopsied, and it showed chronic gastritis. And then for the colonoscopy, it showed seldom polyps. And that's all for the imaging.
This is super, super helpful, and it's a lot of data, and with a lot of findings that we don't commonly see. And I think what I'm inclined to do is focus on the one abnormality that I'm quite confident in discussing, but then discuss with Robbie the other findings and how that influences our DDX. Just to show you what that looks like in real time, we're seeing cyst in many locations. We're seeing cyst in the liver, cyst in the kidneys. We've seen polyps in the gastrointestinal. We don't have a quantity of the amount of polyps. We have a mass in the duodenum. And then on top of all of this, we have pancolitis. So to summarize the ascites and pleural effusion, you could say that this is pan-inflammation of the serosal layers. And with regard to the pancolitis, that's where I would start with. And I would say, are we dealing with one of the eyes? And those eyes include inflammatory bowel disease, infectious colitis, or some form of infiltrative process like a malignancy. If you step back and you say, well, could this be IBD? I don't think IBD would explain all of these findings of the cyst, the duodenal mass, and the pan inflammation of the serosal layers. So then you say, well, could this be some form of cancer? And I think the question of whether this can be some cancer, I think absolutely it can be. I'll be very curious to the biopsy results, because if you think about it, for those patients who present with diverticulitis, what do we often do 6 to 8 weeks later? We end up doing a scope, not before that, because we don't want to cause a perforation, to rule out a malignant cause of colitis, specifically lymphoma. So could this be lymphoma causing a mass in the duodenum, invading the serosal layers, causing pancolitis? Absolutely, it can be lymphoma. And then you're left with the infectious bucket. Could this be an infectious disease? And the truth is, at least to my knowledge and illness script, those infections that cause cysts, I don't really associate them with pancolitis. And specifically duodenal mass, but that's where I'm going to rely on Robbie to comment on. And before I pass the mic to him, I think just stepping back and doing a quick reflection on this case, like this patient, initially their presentation, we said, was most concerning for the weight loss. And here we now know why this patient has weight loss, like all this GI pathology. So Robbie, where I am is like really, I think, prioritizing malignancy. But we'd love to hear if there's any illness, any exotic infection or anything that might mimic this.
You know, Prof. Rez, I'm a little lost. I think there's so many different, it's hard to know what the signal is. I think if you look at this case and if you're looking at this whiteboard from surface, you're like, well, what lead do I trace? And I think it becomes trying something and seeing if it's productive. And my instinct is to merge the renal findings, which I think are hard to dismiss away, because I think the UA is corroborated by the hypoalbuminemia and by the erythrocytosis, and then a prominent GI signal, just to keep it non-specific. So my mind is trying to say, like, what kind of GI issues can occur with nephritic or nephrotic syndrome? And the reason I'm inclined to artificially label it as nephrotic is the patient isn't hypertensive, and so many people have hematuria for other reasons. So trying to simplify it and saying, what kind of issue can have colitis and nephrotic syndrome? And I think I was humbled by a case that was presented on VMR where the colitis was a consequence of the immunoglobulin loss and the patient had C. diff. But I think that appears to be much less likely in a patient without diarrhea. There are many ways to connect to GI issues with nephrotic range disease, and the first might be to think about membranous nephropathy, or as you from a colon cancer, or from a GI malignancy, but also the possibility that the patient has IgA nephropathy from a GI issue, and also the possibility that a patient has lymphoma and minimal change disease. And I think that the idea that there may be some autonomic involvement going on with just how profound his orthostasis is. Also, you could connect it by amyloid and invading the GI tract and invading the glomerulus. Long story short, I think that whenever radiology and basic blood work doesn't give you guidance, your only hope really is tissue. So the fact that we're grasping at such loose ends means that I think a pathologist is probably going to need to make this diagnosis. And it'll be really interesting to reflect on what were the actual landmarks in this case, because I don't have a very powerful place to drop my anchor. Yeah. Thoughts?
I really appreciate you saying that, Robbie, because I'm just like you. It's really hard. I think this is such a terrific case. It's like a show that you watch on Netflix or HBO, like a crime mystery where you can never, like, you guess who the final criminal is, but you're completely wrong. That's what Ariel has me feeling like right now.
It's funny because crime mysteries are my favorite, so it's perfect. All right, so moving along. So during the hospitalization course, the patient's renal function started to decline to non-oliguric ATN, and he also became uremic. We also got the urinary protein excretion, and it showed that his 24-hour urine protein was 15.6 grams. More labs showed his HIV antigen antibody screen was non-reactive. His Hep B and C serologies were normal. And the immune workup, the ANA, double-stranded DNA, and CRP was negative as well. And ANCA, C3, C4, all of that workup was negative. It was a negative PLA2R antibodies as well. And then we got an SPEP. It showed no monoclonal protein detected. The serum immunofixation said the same thing, no monoclonal proteins. And the serum protein immunosubtraction showed no evidence of an M protein. Now, in regards to the UPEP, it showed monoclonal protein present. It showed distinct peaks in the beta region consistent with the monoclonal protein. The urine immunofixation showed monoclonal disorder of free lambda light chain type. The urine protein immunotyping showed a peak of restricted mobility in the lambda lane without a corresponding heavy chain peak, including IgG, IgM, or any immunoglobulins. And that's it for now, because the next part is gonna reveal some big information.
Wow, I mean, this is I mean, I hope you take a second to look at the chat, by the way. I'm not sure. We're just watching you. I don't know if you can see it maybe on your screen, but you shouldn't miss out on what people are reflecting on your case presentation skills. I think what you've shown us is an outstanding workup for systemic causes of nephrotic syndrome. And you've taught us that Hep B and Hep C are two very important causes. You've taught us that lupus, by looking at ANA, is another important cause, and then paraprotein diseases. I mean, you're also teaching us how it can be tricky to diagnose these things. So I'll pass the mic to Profesh to see what he thinks, but I think the crowd should really upload this as a great workup for secondary causes of nephrotic syndrome. I'll just comment on the one that may be least familiar because it's the newest. It's the PALR2 receptor, phospholipase A2 receptor antibody. It is a fantastic, highly sensitive and specific test for membranous nephropathy of it is not only a diagnostic of disease, but actually correlates with disease activity. So it being negative here is almost excludes primary membranous nephropathy, but secondary causes are still fair game. So it's worth reading about this test, because if you don't know about it yet, I think it's going to become mainstream in many places. It's, it's making its way into the limelight. But the paraprotein analysis is really intriguing. And I'll pass the mic to Profesh to see what he thinks about that.
Thank you so much. And I'm going to share my screen here really quickly to show y'all something. So really, is everyone seeing this nephrotic syndrome, the journey? Yeah, perfect. And I think what was so challenging about this case, I'll tell you what was challenging, at least for me. When you're dealing with nephrotic syndrome, oftentimes the only indication for it up front is edema. Like, think about all those patients with lower extremity edema that we say, is it the heart, is it the liver, is it the kidney being kidney insufficiency or nephrotic syndrome. But really, to diagnose it, it's a triad of findings. And almost the majority have this. They have edema, they have a urine albumin that's greater than 3.5, like Ariel's patient, and a serum albumin that's less than 3, just like Ariel's patient was 2.2. I think what happened here was the lack of edema, not fulfilling that triad, took us some time to get to nephrotic syndrome, though Robbie did mention nephrotic range proteinuria, which is different than nephrotic syndrome. And almost all of these patients will also have hyperlipidemia. So very hard to suspect this diagnosis upfront. It's usually once you get the urine studies that and the serum albumin that you really think about it. But now we have a patient with 15 grams of urinary protein a day, who has an albumin of 2.2 and has those urinalysis findings. And by the way, once you do get to this, once you frame it as nephrotic syndrome, oftentimes the biopsy is the most helpful next step, although you can send some labs. And it can be really confusing because you get all these weird names like membranous nephropathy, minimal change disease, focal segmental glomerular sclerosis, or membranoproliferative GN. These are just like the pathological names, and they can either exist as their own entity, which would be like primary, or they can be secondary to an infectious process, a malignant process, or some kind of drug therapy. And then the other three that you have to think about that doesn't necessarily fall within these 4 buckets is IgA nephropathy, amyloidosis, and diabetes. The thing to know about diabetes, probably the most common cause of nephrotic range proteinuria, but a very small minority of those patients will ever develop the syndrome. So Ariel shared with us the SPEP, the UPEP, and the serum free light chain, and everything is pointing to a light chain disease being amyloidosis. Before you can confirm that diagnosis, which is most likely the case, you will want some tissue, and then you will want to Congo stain that tissue, and you'll get the green birefringence. And when it comes to amyloid, the way to think about it is in its 3 forms: AA amyloid, which is a secondary amyloid from some kind of inflammatory process. You have AL amyloid and then transthyretin amyloid. Here, Ariel told us that the light chain, I think, was what was positive, if I'm not mistaken, on that whiteboard. So you're really worried about plasma cell dyscrasia with light chain, predominant disease, AL amyloid. And then you ask the question, does that match the illness group? As I mentioned, that one patient at Hopkins who just had orthostatic hypotension as the only manifestation of AL amyloid. So AL amyloid can definitely infiltrate the nerves. Amyloid can definitely infiltrate the GI tract, and it can cause mass-like structure. Robbie, anything else to add there?
No, I completely agree. I think it's such a great case. We'll see what if this hypothesis bears fruit, but you may be wondering, well, why is the SPEP and serum free light chain and all that negative? And I think you just have to know that in the face of kidney injury, the sensitivity of the serum studies for detecting a paraprotein drops. That's because all the stuff that would have been filtered out by the kidney builds up in the serum and dampens the signal. Remember, in diseases like monoclonal and diseases like amyloid, the paraprotein is this small. So whenever you build up and you have AKI, the ability to detect it on SPEP and serum-free light chains is lower. So the only time you need a UPEP is in patients with kidney injury. Otherwise, we don't order UPEPs. So if you think about this case and you skip that test of getting a UPEP, you would have missed the important signal. So not everybody with concern for paraprotein needs a UPEP, but the sensitivity of the serum test drops in patients with AKI, mandating a UPEP to complete the workup. And I think you saw that point play out here. Alrighty, take us home, my friend.
Okay, so for the bone marrow biopsy, it showed 10% cellularity with clonal plasma cells. And the Congo red staining was negative. Then with the kidney biopsy, it was consistent with renal amyloidosis, the lambda type, AL lambda type, and acute tubular injury. And for the gastric biopsy, the gastric body and antrum specifically showed antral transitional mucosa with mild chronic gastritis, and then no H. pylori organisms identified, no intestinal metaplasia, dysplasia, or malignancy identified. And then in regards to the pylorus biopsy, it showed pyloric and pre-pyloric mucosa with focal foveolar hyperplasia, and reactive mucosal change. And the mass was tested and found to be positive in the Congo red stain for gastrointestinal amyloidoma. So, for the final diagnosis, it showed nephrotic syndrome due to renal amyloidosis, AL lambda light chain, and also multiple myeloma and gastrointestinal amyloidoma.
Ariel, I just want to say what an incredible case presentation. I absolutely love this case because there's no way you could predict the diagnosis until really the end of your case presentation. I would love to hear what you learned from this, but I want to say if you step back and you're like, autonomic insufficiency, GI inflammation, like everything was just glomerulopathy, everything was pointing to your infiltrative bucket of diseases. And when you say infiltrative bucket, that includes stuff like sarcoid, amyloid, lymphoma, and other forms of malignancy. We know that as the SAL bucket. SAL was a huge contributor to CP solvers, sarcoid, amyloid, lymphoma, and other malignancies. Any comments, Robbie, before we give the mic to Ariel and then Deborah to take us home?
No, it was unique for me to sit back and listen to you discuss solo. It was a real treat. And I think you're right. I think the earnest reflection on this case has to acknowledge its tremendous complexity and how many different possible conclusions there could have been at any point in time. I think the Venn diagram that captures the possible diagnoses was very wide until that UPEP came back. So I think we staying open, honest, earnest with that is important. And it's also a great reminder of how easily this case could have gone awry. If you don't get the test, you don't usually get the UPEP, I think you delay this diagnosis. So really, really powerful, important case in general, but important to think about when you get that key test. Thank you. You guys want to tell us what you learned from the case, and then we'll learn the recap from Deborah?
Yeah, I think it's particularly interesting, especially with multiple myeloma, how we know the CRAB mnemonic with the hypercalcemia, the renal dysfunction, the anemia, and like the bone pain as well. And in this case specifically, the creatinine was normal. It was the opposite of anemia. His hemoglobin was highly elevated, and I think it's just a reminder for us to not necessarily rule it out just because it doesn't fit into the CRAB mnemonic. So I think that was one of the interesting parts that I learned from it too.
Yeah, great presentation, Ariane. Yeah, just to add, this played out over 3 months. So there was a lot of noise with this case, if you think about it. So we didn't put in the HPI, but initially presented to an outside facility, and this abdominal pain was worked up, and you see a lot of noise. So you see this cholecystitis, which was made as a preliminary diagnosis. So they went down that route, and he was going to have a cholecystectomy performed as an outpatient. But then the proteinuria, the albumin, was something that was kind of overlooked. Okay, maybe he wasn't eating much, and so he was malnourished. So you can easily blow that off. The other thing is the polycythemia here. If you aren't familiar with this, as Robbie had mentioned, it's due to hemoconcentration because you're just losing a lot of fluid due to the hypoalbuminemia. But then this was kind of an interest, and I kept telling my team, like, why is the hemoglobin so high? So if you do Google in multiple myeloma and polycythemia, there are a few theories. There's also something called Tempe syndrome, where you can have that. Robbie also mentioned, Reza also mentioned, like some of the malignancies, hepatocellular carcinoma, renal cell carcinoma. So malignancies can do it. There's also some mechanism where multiple myeloma could cause localized ischemia within the kidney and then trigger EPO, or localized hypoxemia within the tubules, thus triggering EPO. But it's very uncommon to have polycythemia with multiple myeloma. So you do not usually see this. So that should raise a red flag when going through this. And then regarding the hypothyroidism, which is interesting, that also was kind of a distractor. You're like, what's going on here now? Is thyroid is signaling some disease there. But when you have nephrotic syndrome, you tend to also leak thyroid blinding globulin, and free T4 and free T3 can also leak. So you're in a hypothyroid state, and these labs reflect that. And it's not due to a primary hypothyroidism, but just the fact that you have nephrotic syndrome and just leaking all the hormone and the thyroid binding globulin. So you can actually have a state of hypothyroidism with nephrotic syndrome. So a couple of things to think about that we learned from this case.
Robbie, that's incredible. I think this case can teach you all of medicine if you look at every single aspect of it. Honestly, it's crazy. Thank you both for presenting. All right, Deborah, take us home, please.
Hi, everyone. Great discussion. Really good grades. Thank you so much, Robbie and Ariane. So we had a lot of teaching points. I will try to go for the most important here. So we have like a lot of chief complaints. So the focus was to see which one we could be more concerned about it. Fatigue, diseaseness can be a lot of non-specific. The low blood pressure can cause the fatigue, the weakness, and the disease. And then the patient had like a weight loss of 30 pounds, and we thought that could be inflammatory, infection, malignancy, or an autoimmune, or it could be like something that could cause like a malabsorption, like a celiac disease or pancreatitis. And going for the orthostatic hypotension, we have like 3 buckets to look for. Look for the medication, look for the volume if the patient is vomiting, had diarrhea, peeing a lot, and look for the autonomic system. And then we think about it, what could cause a nephrotic syndrome and the orthostasis. And we thought that could be a diabetes nephrogenic or the amyloidosis that could be infiltrated the nerves and the kidney. And the hyponatremia, even though the patient had a high bicarb and a low potassium, Raza teaches that we should still look for the cortisol to be sure. And going for the ascites and the pleural effusions, we have like a band inflammation. We have to think about the 3 I's, inflammatory bone disease, infection, colitis, or something filtrative like malignancy. And in the end, we saw that the patient had the multiple myeloma without the CRAB, so we have to not necessarily think that it's not this disease because the patient doesn't have the kidney or the calcium or the bone. And the same, we thought about the hypothyroidism that could be influenced by the nephrotic syndrome that can leak the hormone. So yeah, it was a lot of learning today. Thank you so much, everyone.
Deborah, thank you. So I know as tough as this case was for us, it was probably tougher to decide what you want to include in the teaching point because we're all over the place. And Robbie, it seems your expertise is to present just myeloma cases when I'm on. That's going to be number 1, 2, and 3 on my DDX. Thank you all so much. Ariel, thank you for this presentation. I'm going to reflect on this for an hour or 2. I appreciate you. Thank you all. Thanks, Deb.